All right. So now we're getting started with our next lesson, which is on congenital heart disease. Let's begin. So, congenital heart disease is the number one most common birth defect in the world. 40,000 babies are born each year with congenital heart disease. Approximately 45% of babies that are admitted to the ICU at our Children's National Hospital were prenatally diagnosed with congenital heart disease. Every 15 minutes, a baby is born with congenital heart disease. And currently, researchers estimate that 1.4 million adults are living with CHD. In the United States, 50 states are now requiring that the newborn have it's a like an oxygen screening exam, but it's able to pick up critical congenital heart defects prior to leaving the hospital. So just in case if some defects were missed prenatally, this newborn screening is picking these defects up prior to the baby leaving the hospital. So we're making progress in this detections. Okay. So congenital heart disease is in two categories. You have your right to left shunt categories of different defects that are seen that cause blue babies. So these are critical to catch within the first 24 hours of the newborn's life. And then you have your left to right shunt category. These babies not they don't necessarily show symptoms right away. So you may see symptoms later on within their life, either childhood or newborn, but you will eventually they will show symptoms. So we're going to discuss a few of these defects. So starting here, you can see the classification where you see tetralogy of Fallot, tricuspid atresia, univentricular heart defect with pulmonary stenosis, transposition of great arteries, and your total anomalous pulmonary venous return defects are in the category with the cyanotic heart disease. And your acyanotic heart disease are your VSDs, your ASDs, your atrioventricular septal defects, appendicitis arteriosus, aortic stenosis, pulmonary valve stenosis, and coarctation of the aorta. That is in your acyanotic heart disease category. Okay. Okay. So with your cyanotic congenital heart defect, what's happening is that with these heart defects, they're dependent on the ductus arteriosus. So they're dependent on that shunt flow. Now, we all know that the ductus arteriosus closes between 12 to 24 hours after birth. So if you have a baby or baby that's dependent on that flow upon closure, then that's going to create cardiac failure or cardiac collapse. So that's why it's critical to pick these defects up prior to delivery so we can give the baby the help it needs right away. So the main cyanotic congenital heart defects are truncus arteriosus, transposition of the great arteries, tricuspid atresia, tetralogy of Fallot, and total anomalous pulmonary venous return. And I found this finger, it's like a finger, I guess you could say strategy to help you remember these defects. Okay. So, how do they present it? Let's start with one finger. Use one finger to remember truncus arteriosus. Okay. Truncus arteriosus is one great vessel leaving the heart instead of two. So that's with one finger. Okay. Now use two fingers and cross them to remember transposition of great arteries. Okay. So that is when the pulmonary artery and aorta are transposed or reversed. So that's two fingers. Now, with three fingers, you remember tricuspid atresia, and that is when the tricuspid valve fails to form. Okay, so that's three fingers. Four fingers is to remember tetralogy of Fallot, which is four defects into one: pulmonary stenosis, right ventricular hypertrophy, overriding aorta, and VSD. And then your last one, use 5 fingers to remember total anomalous pulmonary venous return, 5 words. And that is when your pulmonary veins connect to the systemic venous system rather than the left atrium. Okay. Now, there are some other defects that are involved in this category, which is hypoplastic left, pulmonary atresia with intact ventricular septum, double outlet right, and double inlet left ventricle and univentricular heart. Okay, so these are all critical ductal dependent lesions that we need to catch right away, right before they deliver. They need help to keep the ductus arteriosus open. Okay, and so here it is again. Same thing what we just went over. Now, if you ever want a copy of this material, please do not hesitate to send me an email and I will send it right over to you. Okay, just for like further reference, or if you want to print from home or so forth. Okay. All right, so this is the newborn screening that I was referring to. So with the newborn screening, they're able to pick up these 7 target areas. So you see it's a hypoplastic left heart syndrome. It can pick up with the screening, pulmonary atresia, tetralogy of Fallot, total anomalous pulmonary venous return, transposition of the great arteries, tricuspid atresia, and truncus arteriosus. So these defects are able to be picked up with our newborn screening. Okay, but it's not total foolproof. It's not total foolproof. Okay. All right. So 1/3 of the congenital heart defects will be diagnosed in utero. 1/3 will be diagnosed after birth. Unfortunately, 1/3 still aren't diagnosed until the baby falls ill or dies. And that's usually, we know, usually through an autopsy, that is why the death happened. So it's critical to pick up these defects prior to delivery. As you see here, I didn't have a recent pie graph here, but in 2007, congenital heart defects were still the leading cause of defects of the infants. So to my understanding, it's still number one, but I think this percentage may be a little higher now. I have to keep doing my research. Okay. All right, so let's get started. So who am I? From this picture, you see a few clues. Can you tell which heart defect is present? Who am I? Give you a second. Okay, and let's find out. So that was an example of an ASD. Let's go back. You can see, it seemed like a very wide hole here, and there was even a star just to point that out. So this is an example of atrial septal defect. Okay, now there are 4 types of atrial septal defects. Let's discuss these types. So your leading or your most common type is your ostium secundum. Okay, so that's 80%. That will make up 80% of your ASDs. It's the most common type. It's usually isolated and it's located in the center of the atrial septum. Okay, now this one will be tricky. Well, why do you think this one will be tricky? Because what else is in the center of your atrial septum? Your foramen ovale. So this will be tricky to pick up. Now your ostium primum is the second most common type, and it occurs in conjunction with other complex cardiac anomalies. And we know where that's located, right at the crux of the heart. Okay. And your sinus venosus is pretty rare. There's 2 types of that one. Sinus venosus ASD of the SVC is located inferior to the opening of the SVC in the right atrium. So the SVC overrides the ASD. And then you have the sinus venosus ASD of the IVC. Okay, so that's located adjacent to the opening of the IVC in the right atrium. And another rare type is the coronary sinus. Now, this will occur in conjunction of a persistent left, which we learned about in that 3-vessel trachea view. I think that was the last lesson I did yesterday. So with the persistent left, there's a dilated coronary sinus and located at the opening of the coronary sinus and right atrium. So that's where that defect happens. Okay. Now, an ASD is best visualized in your subcostal 4-chamber view. And however, it is difficult to diagnose in utero. I did pull out some most common facts here where you can see it's 2 times as common in females. Okay. All right. So here is an example of that. Now, what did we learn about the ASD? You see here, we learned the shunt, right? Left to right shunt. That's what we just talked about. It's in our acyanotic category. And just to reiterate, it is commonly associated with AVSD, partial anomalous pulmonary venous return, persistent left of the SVC, and arrhythmias. All right, so some differential diagnosis. I wanted to show a dilated coronary sinus, which you'll see in a persistent left that causes that left to right shunting. And then I also wanted to point out ASD type 1, which shows the right to left shunting. So you see the difference? And the reason why I showed this because often enough, a dilated coronary sinus is being diagnosed as an ASD. So how do we know the difference between the two? It's the direction of blood flow. Okay, so with your dilated coronary sinus, seen with your persistent left, it's going to have a left to right shunting, which you'll see red because it's heading towards the right atrium. Whereas with ASD, blood is flowing from the right to the left. Okay, and that is the difference between the two. So do not confuse these two upon exam. All right. Another one that is often confused as ASD is when there is redundant flaps of the foramen. So you can see the flaps are almost like touching the wall of the atrium. And it appears that it's a large gap or large hole, but this is normal. This is a normal isolated finding due to the foramen flaps being redundant. Okay, so this should not be mistaken as an ASD defect. Okay. All right, so next one. Who am I? I'm known as a T sign. I am the highest occurrence rate. 74% of me is isolated and will resolve in utero. Okay. And then 75 through 90% resolve spontaneously in the first year of life. 1 to 2% of live born infants have me. What defect is this? I may be single, I may have multiple of me. And I am the most pterygium associated congenital heart defect. Who am I? Any guesses? All right, let's see. This is a VSD. VSD is the most common heart defect. Okay. Now, the VSD can happen in several parts of the septum. And so we just broke it down. So you have your membranous VSD that's located in the upper portion of the septum. You have your muscular VSD. Now, your muscular VSDs are in 2 categories, an inlet VSD muscular or an outlet muscular VSD. So your inlet VSD is located inferior and posterior to the membranous defect. So it's more near your AV valves, okay, your inlet valves. And your outlet muscular VSD is located near or located adjacent to your pulmonary and aortic valves, so near your outflows. Okay, so you see the difference there. Now, there are some other names that you want to know just for your exam, because you may see other names mentioned. So, AKA subaortic, subpulmonary, double A committed, subarterial defects. But this is a least common amount at 5 to 7%. Okay, so you have your trabecular, which is located in the central portion of the septum, and its other name is known as muscular or central defects. And your apical defects are often included with the trabecular defects. It's located in the lower ventricular septum near the apex of the heart, which we know it's here. Okay. Now, some other associations with this defect is AVSD, your tetralogy, your transposition, and your double outlet right. Okay. All right. So pretty much you want to know how, because I think on your exam they may ask about the location or which presentation of the heart should be in order to pick up these particular defects. So please take note, highlight on this particular clip here. Okay, so your muscular, of course, is going to be best evaluated in your four-chamber view. Okay, your membranous type will be best evaluated in your LVOT view. Okay, so let's look. You kind of see here. Okay, so best evaluated in your LVOT view and your short axis view of the aorta and pulmonary arteries. Now, inflow is best evaluated in your short axis view of the aorta and pulmonary arteries. And then your outflow is best evaluated in the short axis view of the aorta and pulmonary arteries. So a lot are with that same view: membranous, inflow, and outflow. And you can see examples here: inlet, muscular, and paramembranous. Just a few examples. Okay. But keep in mind, my exam, it did ask what is the most common congenital cardiac defect. That is a VSD. Okay. Okay. Who am I? There are no hints, but you can just take a look at the pictures and see who am I. All right. So those were example of an hypoplastic left heart and a hypoplastic right heart. Okay. So just starting with the top. We also learned that hypoplastic left heart was under what category? A cyanotic category. So with the left heart being hypoplastic, it's usually caused by aortic mitral atresia. You will notice that there is a decreased size of your ascending aorta, as well as your left ventricle and atrium. You will have enlarged right heart chambers. This will be best evaluated in your four-chamber view. And it's commonly seen in conjunction with a double outlet right ventricle. It's usually fatal. It's in that blue category, so it's usually fatal without corrective surgery. And if found in a female fetus, Turner syndrome should be suspected. Okay. Now, with your right heart, hypoplastic heart is usually caused by pulmonary atresia. So it's going to be opposite. It's going to have a decreased size of your right ventricle and atrium, which causes the left side to be enlarged. This too is best evaluated in your four-chamber view, and is associated with hydrops and heart failure. So let's go back to example. So we can see here, this is the left side that's hypoplastic. Do you see? Because that is the side closest to the spine. So this is hypoplastic left. And with this one, this is your left side because it's closest to the spine. So we see that the right side is the hypoplastic side. Okay. Remember, your right Your pulmonary artery heads towards the spine. So that's how you know the difference between the two. Okay. So hypoplastic left heart syndrome, which we just discussed, it's the underdevelopment of the left side. So you have small left ventricle, mitral valve, aorta, and aortic valve due to the blood supply being inadequate. Okay, so usually there's an absence of blood flowing through the mitral valve and aortic valve, absence or reversal blood flow in the ascending aorta, aortic arch, and foramen ovale. That is a very poor sign. Whenever you see any reversal flow in your great arteries, whether it's pulmonary or your aorta, it is a poor sign. That is a ductal dependent lesion. The right ventricle will become the apex forming ventricle. Pulmonary vein may see reverse blood flow, and when you sample it, you may have a prominent A wave. Okay, and eventually you may see endocardial fibroelastosis within the left ventricle. It may not be appreciated early on in pregnancy, but it will progress. So this is something that you may even see in the third trimester. 20-week could have been normal, but the third trimester may show signs, or vice versa. You may see it. You may not see it at your first trimester screening, but by 20 weeks, you may start to see signs of this. Okay. All right. So who am I? I'm pretty rare, 0.19% of live births. I'm more common in Down syndrome fetuses, and I'm more common in females. Who am I? You can tell. Let's take a look. This is your atrioventricular septal defect. Okay. I did have a question. I believe it was worded basically like, what is another name for this particular defect, I believe. So, yes, it is also known as endocardial cushion defect. Okay. I did see another test question asking, what is the combination of defects that is the result of this defect? And so that's why with the first line I put, it is the result of two defects, which is your primum ASD and inlet VSD. Okay, so it's the combination of the two seen at the AV valve level. It could be either partial or complete. It has a very strong association with T21 Downs. Okay, and the best view is in your four-chamber view, which you can see here. Okay, now this is a partial AVSD and this is a complete AVSD. You see the difference. Okay. All right, so incomplete AVSD partial, the defect is in the lower portion of the atrial septum, defect in upper portion of your ventricular septum. Two AV valves will be seen, okay? Your tricuspid valve septal leaflet and your mitral valve anterior leaflets. Inserts on the septum equally at the same level. So that's when you'll see a linear assertion of these AV valves. Remember, your tricuspid valve should be slightly higher than your mitral. So when you notice that they're at the same level, you want to suspect that it could be a partial AV septal defect. Okay, now here I just put complete AVSD, so you'll know ASD, VSD, common AV valve, 5 leaflets. With your incomplete, you'll have ASD, VSD, separate, you see, MV and TV openings, and a cleft septal TV leaflet. And then intermediate AVSD, which is your rarest form, is ASD, VSD. Your mitral valve and your tricuspid valve leaflets may be fused above that septum, which then divides the common AV valve into separate compartments. Okay. Now, the association that it can also be seen with is with your tetralogy, your double outlet right, your complete transposition. You may notice heart block and heterotaxy. Okay. And you can see all those different variations on this slide here. Okay. Now, I want to point out partial and intermediate equals incomplete. Okay. Only because it's difficult to distinguish between the two in utero. So a lot of times we don't know the distinction between the two because they appear as the same. It's just hard to recognize um, distinct. There's really no characteristics between the two to decipher which is which until after birth. So a lot of times they label it as incomplete. Okay. All right. Just going further. It's pretty much what we talked about. So it's showing the difference between balanced AVSD and unbalanced. I believe I had a question that wanted to know the difference between the two. So with balanced AVSD, you'll have a equally connection. So think because it's balanced, right? To the left and right ventricles, so that each ventricle receives an equal amount of blood and they're symmetrical. So it's balanced. Whereas unbalanced is the AV valve is predominantly committed to either side. It could be your right side, it could be the left side. Okay. And whichever side that is not completely connected to, then the other side results in, because it's getting inadequate blood flow, so results in hypoplasia of that ventricle. Okay. So with unbalanced AVSD, just remember there is like an override on one particular side. The side that is not overriding towards will be smaller because the blood flow is decreased. Okay. All right. So it says complete or partial. Who am I? And once again, you can see the difference, right? This is partial. This is complete. You can really see the difference there. Okay. So this is very, very important. Please, please make a note on this. So if you see an isolated AV septal defect, think T21. Okay. Now, if you see AVSD plus tetralogy, think T21. Okay, so we're still both are in the Downs category. But if you see AVSD and complete heart block, think heterotaxy. Okay, and that's usually polysplenia. Okay, all right. Okay, so who am I? Right away, you should be able to tell from that picture. But who am I? Great vessels are transposed. Pulmonary stenosis is common. Heterotaxy is common. And it accounts for 2.5 of CHD in infants. Who am I? All right, let's go take a look. I am the univentricular heart. Right away, you can see that because where is the septum? There's no division there between the ventricles. It was just all one ventricle. Okay. All right. So there's with the univentricular heart, it is two atrial chambers, but one large ventricle. Okay. Now, a rudimentary ventricle chamber may be contained within the single ventricular mass, and you may see that. Okay. You may have one or two of those inlet valves. You may. It's just hard to say. It's different, like variations. You will have flow into that single ventricle on color, like you see in the example. If there is no flow through one of the valves, consider mitral or tricuspid valve atresia. Okay. Now it's going to usually show some defects with the outflow tracts. So It may show the aorta is anterior and to the left of the pulmonary artery. It may show that the aorta may be anterior and to the right of the pulmonary artery. It's just different variations. Or the aorta and pulmonary artery may be normal. Okay. Now, in your color and pulse Doppler, very important because you want to confirm that the valves are patent. You want to confirm that the aortic arch is connected with your ascending aorta. There's no interruptions. And then you want to assess the pulmonary artery. You want to confirm that there is flow moving forward. You want to check to make sure it's not stenotic or no flow at all. Okay. Now, some extra cardiac anomalies associated with this one is asplenia or polysplenia. So you have to check for that to rule it out. This view, the best view to see this one or to confirm this diagnosis is with your short axis view. Okay, so you know with our typical short axis view, you see both ventricles, but in this case, you'll just see the one because there's no septum. Okay, so here are some cardiac anomalies that may show a single ventricle on your fetal echo exam. You see here, so you have hypoplastic left. And why is that? Because that left side is so small. And so it may appear to be just one. Okay, so hypoplastic left heart syndrome, pulmonary atresia with an intact septum. So that right side is so small, that left side is just taken over, overcompensating. And so it appears to be just one ventricle. In your large or unbalanced AV septal defects, single ventricle in right and left isomerism, in your corrected transposition with tricuspid atresia, mitral atresia with a VSD, double inlet ventricle, and lastly, the tricuspid atresia with VSD. Please know this, you may have a test question that asks something like, are all of these cardiac anomalies may be associated with a single ventricle except. So you just want to be familiar. Okay. All right. Who am I? Who am I? Should be pretty noticeable. I am the coarctation of the aorta. Okay. So you see, we talked about in that 3-vessel trachea view lesson, we talked about the coarctation and its presentation that it will show on a 3-vessel trachea view, which is a narrow aorta and integrate flow. So I did include that here so you can see. So this is how it looks on your 3-vessel trachea view. Sagittally, you can really see the coarc. You can really see that. Okay. The most common location for your coarctations of the aorta is the isthmus. Okay, so that's located between the left subclavian and the ductus arteriosus. The aortic isthmus is the most common location where the coarcs occur. Okay, now there are 3 types. Okay, you have your preductal type, your ductal type, and your postductal. Okay, definitely know the difference between these 3, the locations. Okay, so preductal is the narrowing will occur proximal. Okay, proximal to the ductus arteriosus. Your ductal ones occur at the level of the ductus arteriosus. Your postductal below or distal. Okay. Now, 90% going to occur between where? We just said between the origin of your left subclavian artery and your ductus arteriosus. So your aortic isthmus. It's associated with your Turner syndrome as well as diabetic mothers. Okay. All right. So this is aortic coarctation. I included some values if you want to maybe keep note of it. I included values. So say, for instance, you see or suspect coarctation, you can measure and notice that the mean average for your isthmus is about 3.6. So if you see maybe one at 1 or even 2, you may suspect coarctation, but there's other features that you can see as well that can confirm it for you. Okay. All right. Epstein anomaly. Okay, so Epstein anomaly usually have a strong association with mom using lithium. Okay. And so what are you going to see with your Epstein anomalies? You're going to have a large right atrium, a small right ventricle. There is an inferior displacement of your tricuspid valve, and you're going to have significant amount of tricuspid regurgitation seen with your color Doppler. Now, what I'm showing here in your clip, I just wanted to show on the bottom is normal, and it's you can see where your valves are usually. So I just wanted to show normal versus in a case where there is an upward displacement into the apex. You see, and that is your tricuspid. Okay, so this is your right ventricle, and this is the enlarged right atrium. Okay, this is another one that is a progressive disorder. Okay, so here's another comparison. This is normal. Okay, you see where the leaflet, it should be a little higher, but not, this is too high. This is almost near the moderator band. Okay, these are the difference. Okay, who am I? I'm also known as an aortic pulmonary trunk. I'm best diagnosed with the 5-chamber view. I account for 1% of the heart defects seen in fetuses. I have a strong association with microdeletion 22q, and I'm associated with diabetic mothers. Who am I? Can you tell from the pictures? Your truncus. Truncus arteriosus. Okay, so the truncus arteriosus is failure of the aortic pulmonary septum to form. So there's no division, it's just one big trunk. It divides into the embryologic tongue twister, another tongue twister, but it should divide into 2. Okay, when it don't divide, it's known as the truncus arteriosus. Okay, now this vessel is a single great vessel, as well as it may have a VSD associated with it. Okay, so single large outflow tract with VSD. Type 1 is the most common. Okay, so that is your truncus arteriosus. Okay. All right, so type 1, most common, that is your pulmonary artery bifurcates into left and right branches after it arises from the ascending portion of the truncal vessel. That's what you see here. Okay. Now in your type 2, let's go to type 2. Your right and left pulmonary arteries arise separately from the post-truncus. Okay. Now, in your type 3, your pulmonary arteries arise from sides of the pulmonary truncus. The pulmonary arteries arise from the sides of the single large truncal vessel. This is type 3. And then type 4, pseudotruncus, absent pulmonary arteries. Your pulmonary supply from systemic collaterals from the descending aorta is the source of the flow. Okay, keep in mind though, type 1 is the most common. Okay, we're getting down to the end. Who am I? You see this? We'll look at it again. Okay, let's take a look. Cytology. Now, what I had on my boards It wanted to know what defects make up the tetralogy. Okay, so that is VSD, overriding aorta, pulmonary stenosis, right ventricular hypertrophy. Okay, number four is usually not seen in utero due to the fetal circulation shunts. So that's usually not seen until after birth. But you still need to know the four involved for this diagnosis. Okay. Now, with tetralogy, the right ventricle in utero is usually normal in size. So, once again, you may not see hypertrophy, but typically, if you see those other three, you want to classify it in the category of tetralogy. Okay. Now, I put here at the bottom, the three vessel view may be useful in identifying the discrepancy in the size of the aorta and the pulmonary artery. And you may even see reverse or absent flow in the pulmonary artery. Okay, so that is tetralogy. And that is it. So I finished this part for part one. The next video coming probably within the next hour or so, I will discuss part two of congenital heart disease. Okay, have a great day. Thank you for joining me.